In this case study today, we will be discussing the physiological, pharmacological, and pharmacokinetic effects that different scenarios have on geriatric patients. The first case study we will be discussing involves Miss G, a patient exhibiting abdominal pain, fatigue, and dark stool. During her endoscopy, it was discovered that she had a bleeding duodenal ulcer. She was given Omeprazole and scheduled for another endoscopy in 2 months. 4 weeks after her initial visit, Miss G was brought back into the emergency room vomiting blood. She is said to have stopped her medication after 1 week because the pain had resolved. Take this time to read over this case study one more time. In Miss G's endoscopy, it was determined that she had an ulcer in her duodenum. Peptic ulcers are erosions found within the mucosal layer of the stomach or duodenum. There are many factors that can lead to ulcers, including H. pylori, NSAIDs, and reduced bicarbonate secretion. The bacteria H. pylori plays a role in ulcer formation due to it inhibiting D cells. D cells are in charge of secreting somatostatin, which inhibit gastrin secretion from G cells and HCl secretion from parietal cells. NSAIDs are found to cause ulcers because they inhibit prostaglandin synthesis. Prostaglandins contribute to mucosal barriers and bicarbonate synthesis. Other factors that play a role in the development of ulcers include Zollinger-Ellison syndrome, which is a gastrin-secreting tumor in the duodenum or the pancreas, as well as insufficient duodenal bicarbonate secretion. In Ms. G's case, any of these factors could have played a role in the development of her peptic ulcers. Stimulation of parietal cell acid secretion is modulated by paracrine, neuroendocrine, and endocrine pathways, which bind and activate their receptors. The paracrine effect results from histamine binding to the H2 receptor. This activation increases cyclic AMP, which then activates protein kinase A. The neuroendocrine and endocrine effects result from acetylcholine and gastrin binding to their respective M3 and CCKB receptors. This activation stimulates the release of calcium by the GQ-mediated IP3 and DAG pathway. These signals may also stimulate protein kinase C activity. Protein kinase activation results in translocation of cytoplasmic tubulovesicles containing inactive hydrogen-potassium ATPase to the apical membrane. Fusion of tubulovesicles with the apical membrane activates hydrogen-potassium ATPase, which pumps hydrogen ions into the stomach lumen. An apical membrane chloride channel couples chloride efflux to hydrogen efflux, and an apical membrane potassium channel recycles potassium out of the cell. The net result of this process is the rapid extrusion of hydrochloric acid into the stomach lumen. In addition to its direct effect on CCKB receptors on parietal cells, gastrin also stimulates CCKB receptors on ECL cells to promote histamine release. In this case study, Ms. G is treated with Omeprazole. Omeprazole is a protein pump inhibitor which inhibits the hydrogen-potassium pump in the apical membrane of the parietal cell. It is metabolized by enzymes CYP2C19 and CYP3A4 in the liver. The mechanism of action of Omeprazole can be seen in the image on this slide. In this image, uncharged omeprazole from the blood freely enters the cytoplasm of the parietal cell. Once inside, it then enters the caniculus of the cell, which is highly acidic. This acidic environment promotes the conversion of omeprazole into its active form. The activated omeprazole inhibits the proton pump by interacting with the cysteine residue to form a covalent disulfide bond. The inhibition of the pump prevents hydrogen ions from entering into the stomach, where it is used to form hydrochloric acid. Therefore, by inhibiting the pump and preventing hydrogen ions from entering the stomach, there is less hydrochloric acid within the stomach and the gastric pH levels increase. Protein pump inhibitors like omeprazole are the most effective treatment for ulcers because they prevent the secretion of gastric acid, which helps to maintain the clot in the ulcer. The environment being less acidic in this situation allowed for the ulcer to heal at a much faster rate. This was due to the clotting factors being able to maintain stability in this less acidic environment, which allowed for more platelet aggregation to occur. In Miss G's case, the discomfort she was feeling was relieved because the protein pump inhibitor she was given reduced her acidity and the ulcer began to heal. Four weeks after her initial visit, Miss G is brought to the emergency room vomiting blood. The protein pump inhibitor she was taking inhibited the release of hydrogen ions, which decreased the amount of hydrochloric acid within the stomach. When on omeprazole, Miss G's cells were releasing more gastrin, the hormone that signals for gastric acid to raise acidity levels, in order to combat the downregulation of the hydrogen-potassium ATPase and attempt to raise the acidity. Once the omeprazole was discontinued, there was a hypersecretion of acid due to the high levels of gastrin hormone found within her bloodstream. This is known as hypergastrinemia. Because of the increased level of gastrin hormone being released from the G cells, the ECL cells and parietal cells in the mucosa were increased in numbers, causing a rebound hyperacidity effect. This increased amount of hydrochloric acid can lead to more damages such as acid reflux and nausea. Because Miss G discontinued the use of omeprazole after using it for only a week, the body was not given enough time to fully clot the ulcer. This increased the level of hydrochloric acid found within the stomach, which led to the continuation of bleeding in the duodenum and eventually her vomiting blood. In geriatric pharmacology, it is common for there to be an increased or decreased effect on absorption, distribution, metabolism, and excretion of the drug. For the drug omeprazole, it was determined that geriatric patients have increased bioavailability. This increase in bioavailability is because elderly patients tend to have decreased hepatic metabolism, so the drug has time to be absorbed. Normal range for volume of distribution is around 0.3 liters. This allows for volume of distribution to not be affected by low skeletal muscle mass, decreased liver function, and decreased renal clearance in geriatric patients. The ability of the drug to be metabolized slows as age progresses due to hepatic clearance decreasing. Once the drug has been used to its full potential, it is excreted as a metabolite by the kidneys through the urine. Commonly, elderly patients are not subject to dose reduction because the half-life is so short and they are not prone to high accumulation of the drug. One common issue that medical professionals face in this field today are that patients aren't very compliant. In cases like Miss G, patients are normally tapered off of protein pump inhibitors at a slower rate. When Miss G abruptly stopped taking the omeprazole, a rebound acidity effect occurred. This discontinuation of omeprazole caused a hypersecretion of acid. Because Miss G discontinued the use of omeprazole after using it for only 1 week, the body was not given enough time to fully clot the ulcer, and the increase in hydrochloric acid after discontinuing the drug caused the ulcer to return and reform. This led to the continuation of bleeding in the duodenum and eventually her vomiting blood. In the second case study, Mr. H, an 81-year-old man who has recently moved into an assisted living home, is complaining about being unable to sleep. In an attempt to help Mr. H sleep, he is prescribed Flurazepam. However, 4 days later, he falls in the bathroom and fractures his hip. In this case study, Mr. H is found to be experiencing insomnia. Insomnia is a disorder that causes hyperarousal or increased cognitive, somatic, and cortical activation, which can manifest due to impaired levels of sleep-promoting and neural-inhibitory neurotransmitter GABA. Aging is also found to be associated with impaired sleep patterns, and approximately 50% of geriatric population suffers from insomnia. The ideal pharmacological outcome would be to improve sleep initiation, sleep maintenance without next-day residual effects, and ideally improve next-day functioning. However, it is very challenging to find a drug that will keep someone asleep all night without having effects in the morning. In order to achieve these ideal outcomes, there would have to be a very specific time frame as well as a personalized drug for each patient. In this scenario, Mr. H is prescribed Flurazepam to treat his insomnia. Flurazepam is a long-acting benzodiazepine that is used as a hypnotic agent for short-term management of insomnia. This drug acts by facilitating sleep and increasing sleep duration, all while not affecting the natural REM cycle. The mechanism by which this drug functions is as follows. Flurazepam works on gamma-aminobutyric acid, a neurotransmitter in the brain. Gamma-aminobutyric acid, commonly known as GABA, suppresses excessive nerve activity, which is believed to be the cause of anxiety-induced or other psychological disorders. By allosterically binding to GABA-A receptors, the CNS becomes inhibited. This binding potentiates action of GABA on GABA-A receptors by opening chloride channels within the receptors and causing a chloride influx and hyperpolarization, which leads to the nerve suppressing effects of GABA to be enhanced and the patient being able to relax. As discussed in the previous case study, geriatrics has varying effects on pharmacokinetics. In this case study, Flurazepam is absorbed rapidly because elderly patients have decreased hepatic metabolism, so the drug has time to be absorbed. For this reason, bioavailability is increased. This drug is normally around 83% protein bound. However, in elderly patients, they have decreased ability to make plasma proteins because of their decreased liver function. Because Flurazepam is not as highly protein bound as normal, more free drug is available, giving the drug a low volume of distribution. The ability of the drug to be metabolized slows as age progresses due to hepatic clearance decreasing. Flurazepam is excreted as a metabolite by the kidneys through the urine. Usually, dosage reduction is not necessary for geriatric patients due to the drug's half-life being short and them not being prone to high accumulation of the drug. After being prescribed Flurazepam, Mr. H falls and fractures his hip. It is important to note that most drugs for insomnia are unable to specifically allow for the ideal sleep pattern. This is because each drug would have to be specified to every patient. In Mr. H's case, he is exhibiting side effects that are found most commonly in geriatric patients who take this drug. The reason why Mr. H was having these side effects was because his metabolic rate is not as fast as it used to be when he was younger. For this reason, the drug's effects sit longer in his system. Studies have even been conducted to show that half-life of the drug is longer in elderly men when compared to young men. Beers criteria, also known as Beers list, is a criteria set for healthcare professionals to use when they are deciding the appropriation of a drug for geriatric patients. Both of the case studies contain drugs that were deemed inappropriate for elders. In the first case study, the proton pump inhibitor Omeprazole was used to treat Miss-G's ulcer. While Omeprazole is commonly used to treat ulcers, it has been proven to increase the risk of C. diff as well as lead to bone fractures and bone loss in elders. While it did not appear to have an effect due to her only taking it for a short period of time, continuing it could have led to these effects. In the second case study, Flurazepam is used to treat Mr. H's insomnia. While this treatment is commonly used to treat insomnia, it has been proven to increase the risk of cognitive impairment as well as cause falls, which can lead to fractures and broken bones. Because geriatric patients are more sensitive to benzodiazepines and have decreased metabolism, this drug can have prolonged effects, which can increase the chance of these risks occurring. This was why Mr. H fell, as well as why he fractured his hip.